You know, the evidence is evolving, so I think we've got good evidence to support what we do. I'm a little concerned that the new grads come out and think they already know everything there is to know about manual therapy, so I hope that's not the case. I hope we can convince them, educators convince them that, hey, there's still more to learn. You should continue to go on and do a residency and fellowship and really get more specialized.
Ken Olson, appreciate the time.
Nice to be here.
I've got a list to go through. Private practice physical therapist, past president of IFOMPT, past president of AAOMPT, author of Manual Physical Therapy of the Spine, and this year's distinguished lecturer. That's just a couple of the highlights, but man, I almost ran out of breath saying all that stuff.
Well, thanks.
How'd I land this interview?
You asked and I said yes.
My people talk to your people. That's what we're supposed to say.
Exactly. That's the way it works.
Well, Ken, I appreciate it. You've pretty much been a leader at every level of our profession. You're leading IFOMPT's task force on pediatric spinal manipulation. Do I have that right?
I'm a member. I'm not actually the chair.
Okay, you're on there. Mm-hmm. Why is that work needed, and what misconceptions maybe is the task force addressing? Essentially, what's the purpose of a task force? What is it? What is the task of the force? Let's go with that.
Okay. Yeah. Well, around 2018, there was a video of a Australian physical therapist doing manipulations on a 2-week-old infant, and it created quite a media firestorm in Australia and internationally. And I was president of IFOMPT at the time, and so our member organizations came to us and said, so what's IFOMPT's position on this?
What are we going to do about this?
And I was like, it's kind of complicated. I think we need to get some smart people together and try to figure that out.
Smart.
Yeah. So essentially, we partnered with the International Organization of Physical Therapists in Pediatrics, which is kind of the IFOMPT version of pediatric physios. And they nominated a couple people to the task force. IFOMPT nominated some people. We had Anita Gross from Canada as the chair, and we worked for 5 years just on this topic of trying to come up with some evidence-based position statements to give clinicians guidance on what is and is not appropriate in terms of doing mobilization, manipulation of the spine on children.
Because you don't have authority to just call them up and say, hey, quit it. Right.
Yeah. I mean, we need something to back up the position.
I mean, I'm sure you wanted to call me. I would want to call them, hey, quit it. But it's simple but not easy. So that's why there's a need for a task force, I'm imagining.
Right. Because you're looking at, when you say pediatrics, 0 to 18. So infants 0 to 2, it's kind of easy to say, well, you probably shouldn't do it, but we needed evidence to support that. And then the children 2 to 12, well, maybe as they get a little older, there might be some place where manual therapy would be appropriate. And adolescents, as they get older, you can probably start treating them a little more like adults, but there's some other considerations. So that's what we essentially took on.
Do you take heat for that? Like, I mean, when you're sitting in the big chair, when you're president, everybody looks at you, hey, what are we going to do about this? You got elected, and you're like, oh, great, this is what I get handed. That can't be easy.
Right.
Because what comes out of your mouth is now coming out of the office's mouth.
Right. So, so it was more complex that I could just pull out of the air. So that's where we brought this group together. And actually, last June, there was a special issue of Journal of Manual and Manipulative Therapy where we published our results and made very clear statements that it is inappropriate to do any sort of manipulation or mobilization on infants. And there's also a lot of work that's being done in some areas and some manual therapy groups on treating like non-musculoskeletal conditions with manipulation, things like autism and middle ear infections and ADHD, and really there's no evidence to support that. We came out very clearly and said those non-musculoskeletal conditions, not appropriate. But then, as I said, as you get into children and adolescents, well, there might be room for some mobilization in children and certainly manipulation with the adolescents. So we kind of spelled all that out with the position statements that we published last summer.
You got to go through all that. You got to have the receipts, as the kids these days would say.
Right. Yeah. So we had we published about 7 papers and put together the evidence to support those positions. Yeah. And now the thing is to get the word out because we want. Parents to be careful about taking their children, for manipulation with infants.
Well, because a video can go fast and far and wide.
Right.
But a paper, well, it's harder to get that to move,
Get that out, yeah, exactly. Yeah. So we want, our colleagues to kind of take this and within their circles of influence, try to advocate for appropriate manual therapy in pediatric populations.
Yeah, and informing, right?
Yeah.
Spinal manipulation in children can be a lightning rod topic. We talked about that. How do you balance evidence, safety, and perception when writing global position statements like that? I mean, it took 5 years, so obviously you guys took your time, and care was obviously put into that. But what are some other things that you need to think about when making statements like that, especially when you make it from a large organization like IFOMPT?
Yeah, it's tricky, but when we get into the children and adolescents, when we're thinking some manual therapy might be appropriate, a lot of it is you have to lean on the clinician using good clinical decision making, and so we put that in there. You do it for treating pain and mobility deficits, and trying to be specific with that and good clinical reasoning and integrate it with other things like exercise and education. So it's not going to be a standalone by any means. And because there's not a lot of evidence to support it, so then more research needs to be done in that area. But there's other things, like when it's been used for things like asthma, for instance. There's actually evidence that it does not help asthma, that condition. And so really we just need to stop doing it, and no further research is needed, so that we made statements like that as well.
Here.
Yeah,
right.
Exactly.
We've looked.
Yeah.
There's nothing there.
Right.
Continue on.
Exactly.
Right. But that's not as sexy as a video that can spread far and wide that someone could shoot right now from their clinic wherever they are. It's hard to say, how do you oversee that? And unfortunately, like they say, the lie has speed and truth hopefully has endurance. So hopefully the things that you put out does have the lasting effect that you were hoping for.
Exactly. So we just need more advocacy now, I think, to try to follow those positions.
Yeah. In your lecture, you tackled specific versus general manipulation and that debate. What does the latest evidence say about whether specificity really matters?
Well, there are some large systematic reviews and meta-analysis that showed, it recently came out this summer by Nim was the lead author, and it showed that really the outcomes are about the same when you compare specific versus general manipulation. And this was like 150 randomized control trials, like 12,000 subjects. So it showed that the outcomes were similar on average for that large group of patients, but yet I think, but it doesn't mean we should stop doing specific manipulation in my mind. I think as clinicians, we see that within episodes of care, it is indicated, that maybe you can start with some general things to help with pain and get the good neurophysiological effects that's called, where it inhibits the pain and the patient feels a little bit better. But then sometimes it's just something very specific where the patient's like, yeah, it still feels a little tight when I do this. And you're like, yeah, let me take a closer look. And, we use our knowledge of biomechanics and do a more specific manipulation, then, oh, yeah, that's exactly right. So if you can relate it to what the patient's coming in for, and you can show that, improvement with that intervention, and then give them exercises to keep it moving, it certainly is an important part of an intervention to keep in our arsenal.
Yeah,
absolutely.
Good to think. As somebody who's worn both educator and advocate hats and leader hats, how can PTs become better at communicating scope and safety to other providers and the public? What's some advice? I mean, you've done it at a top level with that task force you talked about. What's some advice there?
I think, you just kind of have to look at what your sphere of influence is, So is it your family? Is it your practice? Is it your colleagues? Can you do things with the local media maybe a little bit? And then legislatures too. Sometimes this gets into the political arena, and you've got to develop that relationship with the local legislator, and politics is local, So being involved in community organizations, I've been a Rotarian for 30 years, and my state rep is in my club, So if there's an issue, he
knows you're coming.
Yeah, he knows I'm there. Yeah, exactly. So I think just having that involvement in your community and and having that reputation as somebody that respect their opinion, and then keeping abreast of what the national issues are, and then kind of bringing that home locally.
Which is again simple, but not necessarily easy, because those things are always changing and moving by pretty quickly.
Exactly.
Yeah. You've seen this profession evolve on the local stage and on the global stage with different seats that you've been in. Where do you think orthopedic manual therapy is headed in the next decade? What are you excited for in the future? What do you see on the horizon? Yeah,
well, I think the evidence is evolving. So I think we've got good evidence to support what we do. I'm a little concerned that the new grads come out and think they already know everything there is to know about manual therapy, so I hope that's not the case. I hope we can convince them, educators convince them that, hey, there's still more to learn. You should continue to go on and do a residency and fellowship and really get more specialized. So I think the fellowships are in a good position. I think specialization's in a good position. The real challenge, though, is can we get paid for what we do? So I think we need to continue to be advocates on, the national level and in Congress to show value. And hopefully society sees value in what we do, so we can continue to get paid for what we do.
Yeah.
So I'm optimistic. There's a lot of enthusiasm and for our specialty area, and I think we really do bring a lot of value with what we do. So I'm optimistic things are going to continue on a very positive trajectory, but still there's going to be some challenges.
Always.
Yeah.
Yeah. Preach. Last thing we do on the episode is called the parting shot. We did not prepare you for this, but that's okay. Just what's one thing that you'd want to leave with the audience, maybe your mic drop moment and your soapbox statement as we wrap up. Any idea, concept, quote, just something you want to leave and have them resonate.
Well, I think it's okay for clinicians to be slow adapters with some of the evidence, some of the research that's coming out. I think that it's important to stay abreast of what's out there, try to integrate it where you can, but don't throw the baby out with the bathwater. If you have techniques that you feel are effective and you can use those effectively with your patients, continue down that path. Now, the reason they work, you might need to learn more about, because some of the old theories may not hold up, but if what you're doing is work, go with it, and continue to use that, integrating exercise and manual therapy and education. And so much of what we do is just sort of connecting with the patient. So the contextual factors, expert clinicians are really good at those sort of things. So, continue down that path. And so I think I want to just tell the experienced therapists, have confidence once you do, stay down that path and learn more about the evidence, but don't necessarily have to be a fast adapter to everything that comes down the pike.
Ken Olson, great parting shot.
All right.
Appreciate the time. Thanks for doing what you do.
Okay, thank you very much.
Thanks for listening to Hands On, Hands Off, the official podcast of AOMPT. Subscribe now so you never miss an episode, and connect with us at aompt.org or at AOMPT on social. Opinions are those of the guests and not official AOMPT policy. See you next time.